get a change in heel tension due to whereas the frequency of
Well, that's the other one, is to actually look at heel tension before and after our
It's
care.
done in every case. That's what I mean. Every time you treat somebody, heel tension is reassessed. And so since that's unmeasurable, I wonder if anybody's ever decided to write about it. Maybe you first have to find out what the hell it means.
Had to first find out if it's intra or inter-examinably reliable.
So it's reliable.
What does it mean generally, the heel tension test?
For me,
Yeah.
it means tension in the neural nervous tissue, spinal cord, dura, brain.
Why?
Why?
Yeah.
I don't know why it does that. I mean, I don't know.
I can theoretically, Dijonet believed it had to do with either atlas relationships or pelvic relationships creating tension along, usually on the short leg side. But one of the things I do in classes a lot is I'll have someone just close their eyes and hold the atlas on both sides and have somebody just pump and they'll feel it move, and it's always a weird type of thing to see that possible relationship. And I think even Mark Pick has done stuff with cadavers where you could actually see stuff going on in the brain, in the ventricular system, as he just pumps a cadaver's ankle. So it's...
Don't you think that might be because of the dural attachment at S2?
Do I think that the relationship between the heel tension has to do with the dural attachment to S2? Possibly. But then why would it go down the leg into the heel? I mean, I have a lot more questions about it than I have answers personally. But
Yeah, myself also.
Can I ask you?
Okay,
we'll go you first.
That was a great study, first of all.
Thank you.
I would ask you, or any of the SOT docs here, in clinical practice, does it make a big difference whether, say, the heel tension is 5 versus 4, or 1 versus 2? In the end, doesn't it come down to a lot or a little?
Yeah.
Or yes or no? Isn't it like clinical practice, it's either there or it isn't there?
Yeah, so looking at it as a
your
yes
choice
or a no.
So your methodology has people rating things 1 to 5, which then lends itself to intra-class correlation for analysis. But had you used a statistical method, which was more similar to clinical practice, where you judge
Yes or
people
no.
as having it or not having it, then you may have shown reliability measures using
That
the
are much
statistic
stronger.
That might have been stronger.
Yeah.
Well, that's just it. I don't know. But
Good
even now,
point.
you could go back and reanalyze your data. Unfortunately, you have a 5-point thing rather than, say, 6. But you could even look at the people that were 5, 4, and 3 and compare them with 1 or 2.
Ah,
And just saying there's a lot or a little. And
Good
then use
idea.
kappa analysis and find out that your reliability was a whole lot higher, I think, than your .55. I couldn't
Yeah.
read it from where I was sitting.
And then
0.5,
also the,
you call that fair, right? Is
intra.
that the word?
Well,
You call that fair reliability?
Inter was fair, moderate.
Inter was fair,
Reliability,
intro
report
is
fair.
very strong.
Yeah, my statistical intuition suggests if you went back and reanalyzed it with kappa, it might
Yeah.
tell a pretty different story.
Thank you.
And I've spent the
I
last
will.
3 years looking studies that reported their data in the form of kappa and done the reverse engineering and reanalyzed it using ICC and found more reliability than people thought. But I think you have the capability for reverse engineering it in the opposite direction.
I love you
But it was a great
statistical
study.
people. Thank you.
Well, I have a question for Dr. Cooperstein. So what's your recommendation for palpation? Because we do lots of epidural thoracic for tracheotomy, lumbar for C-section, and we use the spinal crest for the lumbar and the scapula for the thoracic.
You know what?
And
Dr.
we
Blum
don't
had
miss
asked
all
me to
of it in the
repeat.
right spot, no problem, one shot.
Dr. Blum asked me to repeat your question, but I couldn't hear it, so I could have him repeat your question.
Can you?
Oh, sure. It's the, so what is your recommendations? So what is your recommendations for finding the spot for lumbar or thoracic epidural placement?
You're asking for epidural patients?
Yeah, right. When we're going to do...
I would say the first thing is to recognize that when you're palpating, you're more likely to find L3 or the L3 or L4 interspace instead of L4 or the L4-5 interspace. That's the first thing. And so in the absence of using ultrasonography or radiographic means to find it, if you're using palpation alone, is to use the idea that L3 lines up at the crest. That would prevent you from being higher than you want to be and reduce the risk of injecting the conus medullaris. But I'm exceeding my authority as a manual therapist to say that. But that's my take on having read these 14 anesthesiology articles. That's what they're saying. Do you agree? I mean, I don't know what your profession is.
For us, doing epidural is an empty space, you just put a catheter, it goes up, you reset that, and the biggest risk is getting a dural puncture. But if you're good, not getting dural punctures. But whether you're at L3, 4, or L4, 5, or L2, 3, it doesn't matter.
You didn't ask me about this, but in injecting the thoracic area, what I have found is that the scapula is not a very good reference point because it truly floats over the rib cage. And even to say that it usually lines up with T8 belies the fact that it lies in a range everywhere from T10 to T6. And so being a floating articulation which shows great variability from person to person and even within a person from the left to the right-hand sides of the body, depending on the dominant arm, it's a lousy reference. So I would say people looking for a thoracic landmark would be better served using the vertebra prominens or using motion palpation to find out where they are. And the scapula should not be used at all. And I believe that the anesthesiology professionals, do you agree, has come to that conclusion that the scapula is probably the worst landmark to use. Although in every chiropractic college, I'm quite certain to this day, students are being taught to find places using the scapula, and that is not good.
That shows the T7, but when the patient goes into curving his or her back, like the Halloween mad cat or shrimp, the landmark goes up, and we go 1 or 2 or 3 higher. And it's just about palpation, it's just about the intuitive.
Yeah, it would be better to count down from the cervical thoracic area or count up from the 12th rib or something. There are not many, but a few other methods that would be better.
Right. Some patients are the gastric bypass, the thoracic dural, like 370 pounds, 400 pounds. It's very hard. But one thing I've noticed throughout my career, I've seen some South Koreans, they have 6 lumbar
Different from Caucasians here?
Caucasians don't have around America, but South Koreans have seen 12. These are 5 lumbar, that's 6 lumbar. So that may...
I can see that would complicate things. Yeah. Dr. Blum, I have a question for you. This lover brother relationship thing over there, was it Desjardins who used the term lover brother first?
No, he used R plus C factors. And I tried to find out, okay, well, where's Lovett brother? Where's the Lovett brother?
Who made that up?
I don't know, because when I looked at Lovett's book, I got 3 or 4 of his books from 1908, 1906. Nowhere does he discuss a relationship between the cervical and lumbar.
I first heard of this from the applied kinesiology people, and I contacted Walther and asked him where it came from, and he said he's aware of nothing in Lovett's writing that corresponds, and I can confirm that. I have Lovett's 1924 book on scoliosis and all that, and I've thumbed through every page of it, and I could find nothing in it. This doesn't say it isn't there, but you won't find it in Lovett. No. And I hope he's not turning over in his grave somewhere.
Hopefully not.
Okay.
Desjardins, the first person I saw had said anything about the relationship between the cervical and lumbar vertebra that way.
Thank you.
Can I ask you a question? With regards to the pelvic rotation, so you're saying that they're rotating at the pubic bone?
Yeah.
Okay. And then what's happening?
Do you want me to amplify that? I could. I mean.
Well, I'm just saying, what's happening at the other parts because is it that there's 3-dimensional fascial issues going on that's creating a
Well, the other parts of
distortion?
what? You didn't finish your sentence. What's happening at the other parts of what?
Other parts of the ilium and the sacroiliac joint. I'm just trying to, because it seems like something's happening.
If I weren't afraid of going off camera, I would go get my spine over there. But okay, Dr. Cuthbert will get that for me. I apologize for the sad state of this spine. It was run over
Looks
by
like you
a...
have to carry that with you.
I carried it with me, but unfortunately it was run over by a Coors Bear wagon on the way to the airport today. It's not good. But pelvic torsion occurs like this. I'm twisting it around the symphysis like that. And here's a turn at the screw in the opposite direction. It looks like that.
So let me get this before you say.
All right. I'll repeat that. Since the 1930s, it has been believed...
I had it facing the wrong direction.
All right.
Well, just hold that thought.
I will freeze. Okay. Since the 1930s, it's been established that the pelvis turns like this when it goes into torsion. You see I'm twisting it around the symphysis pubis? And the original proponent of that model is Pitkin and Pheasant, and they pointed out that any other axis of rotation, especially posterior to the symphysis, as this bungee cord is through the sacroiliac joint, would cause this to happen to the front of the pelvis. So if I turn the two innominate bones in opposite directions around the bungee cord, it produces a luxation of the anterior part of the pelvis. If I put it through the hip joint, the same thing happens. It's just not quite as severe. So the only thing that allows the front of the pelvis to maintain its integrity is to twist it around the symphysis. That's what I was saying.
Okay.
And it's been established since then that this is part of the gait mechanism, so that when we are walking, if we are in a phase of gait in which I have, say, heel strike on the left and toe off on the right, in heel strike I, in essence, have a PI ilium on the left and I have an AS ilium on the right. Be the keeper of the spine for one moment.
Yes, sir.
And if I were to magically retract my arms and legs like so that I'm no longer walking, but maintain my lumbopelvis where it was, I would now have what a patient has when they walk in and are diagnosed in a state of pelvic torsion.
Okay.
So this is the model. We wobble around the symphysis over here. It does, as I was saying before, pose a real problem in blocking. Not to clinical outcomes, I'm not going to try to take that away, but whether it's supine or prone, I understand what the high block is doing, but it becomes more problematic what the low block is doing.
The low block's
Because-
stabilizing the high block.
No, no. I think what's actually, well, you can call it that using old-timey chiropractic technique language. It's the stabilization block. But I think what it's really doing is it's shifting weight from one side of the body to the other weight, and in a dose-related way. So the more you push the block under the patient, the more it mechanically pushes more weight onto the other side and on the other block, which is really doing the work. So I see the low block as having an indirect effect.
Well-
It's important, but not in the way that it's usually explained.
I think what if you get outside the bones and think of more of the fascia and the muscle inside, outside, and all around it? Then I think that's where I.
Sign me up. Muscles, soft tissues, and all that. I think we get in a lot of trouble when we keep only looking at the bones that we think we're touching and palpating and adjusting, because what we're really doing is affecting all the soft tissues that connect all the bones.
Yeah.
And I think a lot of the way out of the morass created for us by the high-tech studies will be solved once we realize that we're not really touching the PSIS or anything of its kind. We're touching the soft tissues like the sacrotuberous ligament and the gluteus maximus and all the rest that are moving around where we thought we were touching the bone. And I think we can salvage a lot of what we think is going on by recognizing that we're really palpating and visualizing soft tissues and not the bones that we're constantly talking about.
I like that. Okay. Any other questions? Okay. I want to thank everybody for coming. Please get ready for next year. We're going to do it again here in New Orleans, I hope. And if you have any sort of papers, any sort of interest of something, please think about it and submit it, and let's do it. Thank you so much.
Thank you.
Thank you.